The Quality in Acute Stroke Care trial was a clustered randomised controlled trial involving over 1,600 patients and 19 acute stroke units in New South Wales, Australia. We developed 3 clinical protocols, one to manage fever, one to manage hyperglycaemia and one to manage swallowing difficulties. But we knew if we just sent the protocols out to the stroke units, it wouldn't necessarily change clinician behaviour. So we wrapped it up in an evidence-based implementation strategy. The results of the trial were very positive. We found that patients who were cared for in stroke units who were allocated to receive our intervention were 16% more likely to be alive and independent at 90 days.
The uptake of the fever, sugar, swallowing protocols within the stroke units that were randomised to the intervention arm was around 50%. That level of adherence still resulted in a very robust benefit for patients in those hospitals. But of course, if you can boost it higher, perhaps the benefit may have been stronger.
We published the results of the main trial in the Lancet, but we know that just having a publication isn't going to be enough to get people to actually adopt the practice on a wider scale. I approached the New South Wales Agency for Clinical Innovation. We were funded for a 12-month project to roll out implementation of the fever, sugar, swallow protocols in all 36 stroke services in New South Wales within a 12-month timeframe and with a very rigorous evaluation program around it.
We were mindful that we needed to take a pragmatic approach. We were unable to necessarily control everything as tightly as we were in the trial, but we adhered to the implementation strategies very strictly.
We took the fever, sugar, swallow clinical protocols and also the implementation strategy of the original trial that involved multidisciplinary workshops to establish barriers and enablers, local clinical champions, site support and reminders. Those champions came to us for a one-day workshop to become local project officers. So this allowed us to very quickly run this implementation across the state.
St Vincent's Hospital was involved in the original QASC trial as an intervention site. I think it was important for St Vincent's Hospital to be involved in the QASC Implementation Project because we know that these protocols work, we know that they reduce death and disability. Participating in this project provides a real structure and basis for us to move forward and ensure that these protocols are being followed by all nurses all the time.
I first heard about the QASC trial in 2011. We did attempt to implement it prior to this project. Probably some of our barriers were that we didn't do enough education and communication. When we had the opportunity to participate in the formal implementation of the QASC trial, we thought we'd do better with the backup, and that proved to be the case. We had good clinical support around our questions. The audit tool made it much easier to monitor how we were going and to feed back to the staff.
Evaluation of projects such as this is crucial. We formed a unique and very positive collaboration with the National Stroke Foundation, who already run a 2-year audit cycle in stroke.
The importance of evaluating a process such as this is paramount. How does implementation research actually look to chief executives of local health districts? Are there better outcomes for their patients?
We were very fortunate with this project in that as the researchers we were actively involved in the rollout of the fever, sugar, swallow protocols. We knew the research backwards, we knew exactly what we had done and we wanted to replicate exactly what the study had used to roll out the project.
There were some occasions where people wanted to add implementation strategies, and as the original researchers we were able to rein them back in because the implementation strategies are meant to be just light touch so that all sites are able to replicate these kind of implementation projects.
It's incredibly important that Health in New South Wales partner on every instance that's available with academic institutions to actually provide a research background of what's clinically happening and get the best outcome for the patients that are treated in New South Wales public health facilities.
One of the biggest challenges for the QASC Implementation Project was the geographical spread of all the stroke services involved in the project. some of our hospitals are over 600 miles apart. We also have to allow for local adaptations and be pragmatic in that approach, considering the vast amount of stroke services with a huge variation in size and resources for something like this to be successful.
I think the key takeaway messages from the project is that upscale and spread of even proven interventions requires dedicated funding. It's important to be true to the original research, not to augment it in any way. I think there's definitely value having academics working with industry. They make a fantastic collaboration, and we must make sure we rigorously evaluate projects such as this.
This is the first major study really to show us that within the stroke unit structure we can tweak it further and get even more benefit for patients. If you do these simple things well, your patients with a stroke will do better, and it's something that can be internationally adopted and help patients globally.